So when you say mass, I know it's more than 3. When you say nodule, I know it's somewhere between actually 1 millimeter, 1 centimeter and 3 centimeters. Less than 1 centimeter is what we call miliary shadow, or miliary shadows, or miliary nodule. Last but not least, cavity. Cavity lesion means there is a wall, a hollow structure, within the lung, with a wall. This is the meaning of a cavity. This cavity could be air only, it could be fluid completely, or it could be air and fluid interface together. Okay? So, how would you describe this out of all the terminology? Just regardless, how would you describe the abnormality here?
Infiltration.
Any other guesses? Infiltration possible?
Air bronchogram.
Air bronchogram, most likely. Infiltrate. This is an infiltrate. So you can see the actual aeration here in the airways, over a consolidated lung. This is a patch of an air bronchogram. Okay. On the right?
هاي two masses. واحدة nodule وواحدة mass.
So mass on the left, nodule on the right. Okay? Just by terms.
Cavitary lesion.
Mm-hmm.
Air fluid level.
Yes, cavity lesion. So it's a cavity. Depending about what it is, but it's a cavity, so there's an air fluid level. And here? This is more of an infiltration. This is infiltration. Yeah, bilateral diffuse infiltrates. Good. So again, you want proper identification. You want to ensure that there is a good quality in your radiograph. Basically, I'm making it just more concise. Adequate clinical data, previous examinations that you have, or previous films. And then at the end, you're going to possibly find either it's going to be normal or you're going to find a pathology. To make it easier for you, out of all the pathologies, I'm going to just concentrate on lung. If there's lung pathology, there's an abnormality in the lung, there's a lung lesion. So meaning the parenchyma. If there is a lung lesion, I just want to make it simple for you as much as possible. When you see a parenchymal problem, it's either going to be focal, like for example this one. Okay, it's going to be focal, like this. This is focal, right? Focal. Or it's going to be diffuse. So I will tell you, small scheme, if it's diffuse versus if it's local. To make it easier, just only lung, only peripheral out of all the diffusion. So diffuse lung lesions, if you have a diffuse lung problem, you're going to have to place it within one of those 4 when you describe it. Okay, simple. So X-ray, problem, bilateral, diffuse, I have to classify whether it's alveolar, which is like the air bronchogram we saw, but it's bilateral. This is something that we see with cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. It's bilateral, and it's diffuse, and it's an air bronchogram. Or if it's reticular, interstitial lung opacity is like the X-ray that you had just seen. Or if it's miliary and it's numerous minute nodules, and this is usually happening, commonly we see it here with miliary TB if it presents, but there are other differential diagnoses for this. Or if there is cystic pattern, so we have we have the cavity, the airflow level, but we have it multiple in different areas of the lung. Yeah? Okay? So you have to identify if you have bilateral and you have diffuse, which one is it going to fit into? Is it reticular, is it alveolar, or is it miliary, or is it cystic? What about if it's a focal lesion? So it's just one lesion in one area. You want to know how many are those lesions. It's just 1, 2, in specific area. If it's well defined or if it's an ill-defined one. Okay, which is what we say characterization of a focal lesion. Now, the 4 categories for focal lesions, if you see a focal lesion, it's one of 4 things also. So if it's diffuse, we know 4, and if it's focal, there is 4.
معلش ممكن بس السلايد اللي قبل بس
Yes.
ابص بصراحه. لا اسمعش.
No problem. احنا قلنا في evaluation of chest X-ray quickly again. I'm just making it small. تمام? No proper identification, ensure quality, adequate clinical data if you have examination, and then I'm going to make it a little simpler for you. Although we evaluate a lot of things, بدأنا بالsoft tissue, I'm just going to concentrate on lung because this is the most important area, right? So to make it easier for you for lung, just think: is it diffuse or is it focal? If it's diffuse, 1 of 4, and if it's focal, 1 of 4. You can call it rule of 4 if you want, it's up to you. تمام? So the 4 regarding diffuse, you have to classify the diffuse as either being reticular, alveolar, miliary, or cystic. And if it's focal, then it's either a nodule, a mass, a cavity, or a patch. And we've already seen those examples. Patch meaning there is an air buccogram in a certain area, and we've seen it. Cavity meaning that there is a well-defined area which is partially or totally filled with air. A mass is more than 3 centimeters. A nodule is somewhere, a well-defined lesion somewhere between 1 and 3 centimeters. Fine. When you characterize a pulmonary nodule, you have to comment. There are things that you have to say, like you're calling me, so Mahmoud Alou, there is a patient that has a nodule in the left lower radiological lung zone. مش low, radiological lung zone. طيب. It's subpleural, it's rounded, well-defined border, it's about 2 centimeters in size, in the maximum diameter, all these issues. So how will you characterize it? This is how. You comment on size and number. Why is it important? Because usually 80% of nodules are usually less than 2 centimeters, are usually benign. So if you have a small nodule, most likely we're dealing with a benign issue. And the multiple nodules are rather suggestive of metastatic pathology. So you'd be more concerned with multiple nodules. طبعا growth rate is something old we used to depend on. Now, because of the high availability of CT and HRCT, usually we do CT imaging. We do CT imaging and we follow by something called the Fleischner classification of pulmonary nodules. And there's like different graphs according to the number, the size, the risk factor, how to follow up each one, which one to dig for and which one to wait and follow up. Yeah? But before we used to depend on something called the doubling time. So we should just follow by simple imaging the nodules and see if the doubling time meaning how long will it take this nodule to double in size. So if it's 1 centimeter now, how long will it take this nodule to reach 2 centimeters? If this doubling happens within 1 to 15 months, then we used to say it's a pathology or it's an active problem. We have to pursue by biopsy and so on and so forth. طبعا calcification is something that calcification, if it's present, it's usually suggested benign rather than malignant. If the calcification may happen in malignant conditions, also malignant nodules, then it's usually eccentric. Meaning it's always towards the outer aspect of the nodule. So up to 60% of benign nodules and 90% of malignant nodules may not contain calcium, which is meaning it is very, very less likely if there is calcium it will be malignant. The margins, of course, if it's smooth, well-defined margin, it's most likely to be malignant. Doesn't mean it is, but most likely. If it's ill-defined or it has a speculated border or infiltrative border, that means it's highly suggestive of being a malignant process. What are the common nodules? Let's say you actually face an X-ray where there's a focal lesion and it's a nodule. Okay, so what's the usual differential? What would you be thinking about to generate a differential? Commonly, it could be a tuberculoma. It's very common. Something that we all go through when we get infected with a tuberculous bacilli. It actually goes to the lungs, to some area in the lungs, and it becomes dormant there. And it just stays there. Yeah? So tuberculoma is usually single. It's located usually in the upper lobe and mainly on the right side. Why? To remember that.
More aeration.
No, because the blood flow when we get the TB primary infection, usually it goes with the blood flow. And when it goes with the blood flow, okay, the right side usually has more blood flow, and usually when it goes by blood, it reaches there, and the blood flow usually goes more towards the middle area. So it's usually somewhere in the posterior lobe of the right upper lobe or the superior segment of the right lower lobe. So it's somewhere close to that area of the fissure, either below or above or below. It could be a hamartoma, which is just the usual abnormal collection of tissues, and usually there's calcification in a small number of those hamartomas. It could be a peripheral bronchogenic carcinoma, just a solitary subpleural nodule, in about 50% of cases high risk, especially if it's subpleural and it's in the upper lobe in an actual smoker, then it's likely to be a malignant process, okay? So as we said, if it's upper lobe in 70% and it's subpleural in about 50%, then you would probably be more suspicious about it. If it has a speculated border, then definitely we're talking about malignancy. It could be also metastatic. Metastatic deposits are usually multiple. It just makes sense. Because usually what happens with metastatic deposits to the lung is that it's coming it's bloodborne. Usually it's not lymph node, it's actually bloodborne. And when it comes bloodborne, it just spreads everywhere, and it's the same thing. Remember that the blood flow, usually you find more on the right side than the left side because of the blood flow is usually more stronger on the right side. تمام. It could be any size, smooth edge, usually they don't have calcium, but it could be also a characteristic cannonball metastatics, which cannonball metastasis comes from where?
Bladder or
It can come, it comes from the urinary system, usually from the kidney, and otherwise it can also come from thyroid. Okay, it can also come from the thyroid. It can come from the from the germ cell tumors. تمام. The genitals can happen. The last thing is pulmonary AV malformation is usually we don't need to concentrate on that, but it is one of the differentials. It's usually simple and 80% could be complex. Usually it's lower lobe. Why lower lobe? Because there is more vascularity down there, basically. Yeah? So it just makes sense to be more common in the lower lobes than the upper lobes. It's usually well defined and it looks like a vascular cord. But of course the definitive diagnosis will be by CT imaging with contrast. Hydat cyst, you guys know, if it's just one cyst, usually it's variable in size. It could be also multiple, but it can come single and it can come unilateral. So it's one of the differentials here. It's the last on the list. But it has a thin wall and it can have a fluid level. What about masses? So nodules are simple. Basically, what you're really afraid of with the nodule is that it's malignant. And we know the characteristics of that one. Otherwise, it's usually benign as a tuberculoma, hamartoma, hydatid, and AV malformation. What about masses? It's more simpler. I think there's just 3 on your mind. Basically, when you see a pulmonary mass, it is bronchogenic carcinoma until proven otherwise. Okay? طبعا, it depends on the mass lesion. If there's speculated border, plus or minus calcification, associated lymphadenopathy, associated pleural effusion, any other associated changes in the lung that may suggest a malignant process. Usually, with those, CT is mandatory for a proper assessment of the actual lesion, the site, the size, because we can determine, there's a classification called TNM, so you can basically classify it furthermore, and then decide which is the best way to actually biopsy and diagnose. Hydat cyst, we already mentioned, they're usually solitary in about 75, but they could be multiple, 25% of cases. They're very well circumscribed. They can be pretty big. I mean, they can reach even more. I've seen some even more than 50 centimeters. What we're trying to say is that they can get really, really big. They can become really huge. It usually has a water component, water density, and gives you something called a water lily sign, because the actual organism might be floating inside it. Cavities in general, they could be either partially or totally contain air. Cavity may have, as I mentioned in the beginning, it could be just all air. It could be all fluid برضو, تمام, before it breaks down. It could have air and fluid or even air and soft tissue. تمام. Intracavitary lesions that might be possible, especially if there's soft tissue. You might have a tumor breakdown, or it could be a fungal ball. A lot of cases with TB that have a cavity, prolonged cavity, are likely to develop fungal infection on top. And this is usually aspergillus, it's a aspergilloma, what we call aspergilloma, inside the actual cavity. So any of those may be complicated, even by hemorrhage. So if you have a cavitary lesion, basically what happens is that you're going to depend on the content and the thickness of your wall. So if you want to characterize it immediately, what you're going to do is that you're going to look at the context. If there's air only, okay, only air, simple, just look at the wall thickness. If it's thin, we're probably dealing with an epiphysematous bully, alright, or an omatocele, depending on where it is. So if it's peripheral, then most likely it's an epiphysematous bully. If it's central, it's an omatocele, okay? What about if it's thick? If it's thick, look at the actual wall. If it's a regular wall, it's more of a chronic problem, so it's a chronic abscess. If it's irregular, that means there's actual speculation or infiltration. It could be a malignant cavity, yeah? What about if there's air and fluid? Look at the surface. Usually, it's very difficult to determine. So usually we CT those patients. If it's air and fluid level, everyone knows the next step is to do what? Is to do CT. Yeah, to determine what's going on. CT and scope. Usually, most of those cases are usually scoped. So you look at the surface. If it's a straight surface, it's an abscess. If it's a wavy surface, it could be hydrated, يعني water lily sign. So this is a nice. So what we're trying to do is we're trying to just simplify, trying to compact it so that it's easy. Yani let your mind go with the X-ray as an algorithm. You're just ruling in or ruling out things. What about the pulmonary patch? And we talked about nodule, masses, we have patch, and the patches, طبعا pneumonia. When you have an airspace disease, usually if it's an airspace patch, it's possibly a pneumonia. طبعا it could be, before we used to classify them as regards the organisms. I used to say it's a typical lobar pneumonia, it's pneumococcal. If it's not, if it's bronchial pneumonia, it's staphylococcal or streptococcal. It's not related. Any organism can do anything. تمام. What I did is that I just brought in the new ones. So it could be an airspace, يعني lobar pneumonia. So it's lobar pneumonia, regardless if it's pneumococcal or any other disease. It could be a bronchopneumonia, multiple patches related more to the airways, so it's more central than peripheral. Or it could be an interstitial pneumonia, like the ones we see more commonly with viral or atypical infections. But it doesn't mean any one of those organisms can do any of those. Yeah? طبعا, if you have extensive infections or multiple factors, then you can have different patterns in the same patient. So you can have a lobar pneumonia in an area and then a bronchopneumonia picture on the other lung, for example. Yeah? Okay. If it's a pulmonary infarct, it's easy. We all learned it. Pulmonary infarct is peripheral, it's wedge-shaped, and usually the base is towards the pleura and the apex is towards the hilum. There could be associated pleural effusion. Okay. The effusion could be unilateral on the same side, or it could be bilateral. Filling defects in the pulmonary artery on CT angiogram, which is basically the diagnostic test to rule out pulmonary embolism. طبعا VQ scan.
هي الباتش موجودة بالرايت. How will the effusion say bilateral?
Okay, excellent. So in PE, effusion could be exudate and could be transudate. تمام? 2/3 of cases are exudate, 1/3 are transudate. Now the idea with PE or a pulmonary infarct is that usually the infarct itself causes يعني release of inflammatory cytokines, and it causes an inflammatory reaction which causes the consolidation and possible pleurisy and associated pleural effusion on the same side. Now, if the PE is significant enough to cause cardiac compromise, okay, then it will give you a bilateral effusion due to hydrostatic problems, which is related to cardiac. But without cardiac compromise alone, so that's why most commonly it's unilateral and more commonly it's exudate because it's related to the actual reaction. Yeah? But we found in some cases yes, related to cardiac compromise. And those are the patients that have elevated troponin, right-sided strain, so on and so forth. Okay, so again quickly. So what we did today basically is that we discussed basically an optimal X-ray, tamam, as regards usually the position, tamam, is about 6 feet from the tube to the thing, and we talked about the penetration, the positioning, the labeling, yeah, all the things that we want to make sure that our chest X-ray is fine. We talked about different types of X-rays, yeah, each clinical indication for each one, يعني as regards mainly the frontal, APPA, the lateral decubitus, tamam, all the other types we mentioned, and then we spoke about how to evaluate in general on a chest X-ray, the actual routine about how to clear off, but we concentrated today on lung lesions. If you have a lung lesion, okay, not plural, but lung lesion, how can I make it easy for myself to be able to characterize? So if it's a lung lesion, it's either focal or diffuse. If it's diffuse bilateral lung lesion, then you have to characterize the diffuse as into alveolar, reticular, miliary, or multiple cavities or air fluids. Yeah. طبعا if it is focal, we talked about nodules. Yeah, about characterization of those nodules and the differential diagnosis, masses, okay. We talked about patches, and we talked about how to characterize cavity, if there is one, okay, according to the position and the wall thickness and the content. Yeah, good? So you guys are ready and you're comfortable enough to start to practice, tamam? Okay, so anybody want to shoot with the first one? The most common one we all see in all settings and everywhere. I always start with the comment طبعا. And we're going to build up. يعني I'm going to try to build up to see how you guys can actually يعني get more from the chest X-ray. تمام؟ أشيع سبب إحنا بنقوله أشيع سبب. What do you think?
We don't know AP ولا PA.
It's most likely what we discussed it today.
AP.
Usually when you have loss of fundic air bubble, تمام, and usually the scapula طبعا يعني is encroached and you have electrodes, تمام, like this, usually it's an AP. It's very difficult for a patient like this to actually stand up and do a PA. So it's AP. But generally,
You're talking
High
about.
level, there's high problems of the high level.
yeah, يعني there's bilateral diffuse airspace disease that's mostly central more than peripheral. تمام, in a patient طبعا like this with يعني borderline cardiomegaly, يعني this is more suggestive of yeah, which is cardiogenic pulmonary edema. This is more suggestive of cardiogenic pulmonary edema. This is common, and you guys probably see this commonly. تمام, so this is the most common, it's cardiogenic pulmonary edema. So quickly, if you don't want to waste time, it's يعني when you look at it, it's focal. It's a focal. Let's say it's a focal. And then what does it look like? What type of focal? Patch. Patch. Airspace. صح? Patch. Right?
We hyperinflation of the chest.
Let's concentrate. أنا هconcentrate على pathology على طول معاك عشان بس تبقى easier. So it's where is it?
In the high
Mid zone, pass.
Okay. Mid zone. I like mid zone. So it's not middle lobe. So it's mid zone basically. Yeah.
Oh, there is a patch.
So it's right paracardic. It's obliterating the right cardiac border. We can't really draw the right cardiac border. So it's obliterating the cardiac silhouette. So right cardiac silhouette. It's a patch obliterating the right cardiac silhouette. Looks like an airspace disease. It's most likely consistent with
Low pneumonia.
pneumonia.
okay, pneumonia. Would you like to order something else?
No.
Please. تمام. This is the lateral chest X-ray.
Okay, let's switch.
So where does it look like it is? احنا قسمنا. Usually احنا عندنا الفيشر نازل كده. تمام. And this is right? So so it looks like it's in. Is it in the middle? It's the right middle. Simple. Quick. Simple and quick. Okay. This is just. With time, we want to dwell more. I want to make sure that we're just getting the safe. Okay. Let's try again. يلا again.
عبيد معلش لا بقول لك مين هنا
Which عندنا patch.
Yes.
Lower zone.
Right lower radiological lung zone. Okay. Which silhouette's gone here?
عندي diaphragm.
Excellent. So here you can actually completely visualize the diaphragm. So there's no way it's in the lower. Okay? But in this one, you can see this, you cannot visualize the diaphragm. So the right diaphragmatic silhouette, somewhere. It's gone. There's a patch. It's airspace. تمام? You cannot even get, yeah, you can barely see the cardiophrenic angle, but you cannot see the right costophrenic angle. If there's effusion or not, we don't know. You'd want to do more, but you don't know. But there's definitely heterologous opacity, it's an airspace disease on the right lower. You want to do lateral,
Yes.
and then you find,
Lower lobe.
so it's consistent with a right, lower, lobe. Pneumonia, by the way, and I cannot see a double diaphragmatic border here. Usually any pathology related to the right lower lobe, تمام, mostly effusion, the double diaphragmatic shadow will not be there in the lateral, so you lose it. So this is basically right lower lobe pneumonia. If you think there is associated effusion, then you can do
Lateral decubitus.
what بقى قولي لي بقى على طول بقى right lateral decubitus.
إيه.
عودي نفس الدكتوره.
right.
ها لان طالما lateral ممكن هو ينزل يعمل ايه على الليفت. يبقى الفلويد كله في الميديستاين will not do anything. So right lateral decubitus if you suspect that there is, or you can.
Ultrasound.
Yes, you can see if there's fluid and consolidation. Now it's more widely used. تمام؟ Okay. Good?
Good.
تمام.
Okay, في
It's gonna get tougher طبعا.
واحدة بronchograph.
Where?
Right lung.
So here? So this is not normal vascularity.
هذا
احنا لغاية الاوت the first يعني the inner 2/3 acceptable to see vascularity. Beyond that, and when you say even increased bronchovascular markings, that means the markings are all evident towards the end and in the outer 1/3. That's when you say there is. But is the pathology in that? So let's go basic. If you get stuck, you don't know what's going on, but you think there is something wrong, then look, soft tissue looks fine, airway looks fine, centralized. Yes, patient's well centralized. Down here, this looks fine. This looks okay. Maybe the waist is obliterated, but no problem. Can you follow the left cardiac border?
No.
What happened? Silhouette sign. You can't follow it, but can you see the diaphragm?
Yes.
Yeah, and we can see most of the diaphragm, although it's still obliterated here, but already left cardiac, but I can see the rest of the diaphragm here, clearly. Then this side's fine, the hymen looks okay, little vascular here, right cardiac border, this looks fine. So there's a pathology here.
Mahmoud, is it okay?
Yes, more or less it's okay, it's acceptable.
Left.
خلي بالك الفيلم هنا كمان is hard.
Yeah.
It's hard. So this is where you start picking up. Yeah, you start understanding, it's more bathtub. How is the exposure? No, it's hard. Doesn't mean I can't, but there's a pathology here. It's hard, but there's a pathology. تمام? Okay, can I say this is increased vascularity? No, it's too hard of a film. Maybe if we fix the exposure, it's gonna look fine. So there's a problem here. Usually the lobe that's related to the left cardiac border and not affecting the diaphragm is which lobe? The lingula, which is equivalent to the right middle lobe that we just did. Okay? So what you'd like to do? The lateral. تمام? It's not very clear, but there is an increased opacity طبعا down here. تمام? But it's overlapping with the heart. But as you can see, the lower is completely clear. Completely clear, yeah? So what would this be? It would be a lingular pneumonia. What about this?
Patch in the right upper lobe.
Yep.
Increased vascularity in both lungs.
So thank you for saying patch. So هنا بقى what happens it's just it's still an air. This air bronchogram is amazing, تمام? It's this look you can actually draw the vessels. طبعا not all the vessels. This is 2-dimensional. So we're just احنا حظنا we're just seeing the vessels that are going up, but there's many vessels going to the back and going to the front. We can't see them. They're going to be rounded. And when you take a slice, if there's a vessel going like this, it's gonna be rounded. It won't be shown, but those are well shown, تمام, as they're going up. So there is extensive airspace disease, right? It's more extensive related to the actual fissure, and the fissure is drawn, so it's obeying anatomy. It's not crossing the fissure. تمام? So this defines the right upper lobe. It's extensive. It's basically طبعا يا اما anterior or posterior, ده شكله posterior. All of it, even the apical is involved, but there's more dense pneumonia here. It's the same thing. It shouldn't change. تمام? When you do a lateral, it shows more increase in the posterior than the anterior. Yeah? But all of the upper is affected, mainly the postero-apical segments are affected more, and this is still a right upper lobe pneumonia. Simple. It's just more dense. Does it correlate clinically? Does this mean this patient's more sick than the one we saw before? No. Maybe the one we saw before is even more sick and more tired and having more systemic inflammatory response than this one. Will it differ in the management? No, it should not. Same management, same outcome most likely. Yeah? This is the 10% mortality here, 10% mortality. You know what I'm trying to say? It doesn't, but it's still just different radiographic findings. Okay? So diffuse alveolar, basically what I want you to come out with is that if there's diffuse bilateral alveolar, the first X-ray, then there's edema. It's either cardiogenic or non-cardiogenic. More commonly what we see is cardiogenic, or it may depend on the clinical. If the patient's non-cardiac, he's coming, he's hypertensive, high BP, you know what I mean? Or if he's coming with severe infection and sepsis and he has or coming with pancreatitis and you find this, or septicemia, urosepsis and septicemia, and you find, no, then I'll be more with non-cardiogenic. So, pneumonia طبعا احنا عارفين عادة بيبقى طبعا more local, but it could be bilateral. طبعا الديفيوز بيبقى أكتر، أنا حاطط على الفيرال أكتر. طبعا إن هو usually الفيرال atypical بيدي bilateral, but it's mainly either edema or pneumonia. طبعا it could be blood because it's still fluid. What we see is fluid in the airways. So it could be blood, whatever the cause is. تمام؟ طبعا less likely طبعا أكتر الtumors في يعني blood malignancies that infiltrate the lung as يعني simulate pneumonia by infiltration. طيب, what about this?
Left lower.
Yep. You can see the left cardiac border here. It's clear. طبعا it's confusing when it's next to it, but can you see the left cardiac border?
Yes.
Can you draw it? Yes, we can. We can draw the left cardiac border all the way down to the cardiophrenic angle.
Okay.
So I wouldn't say lingula. We'd say most likely we need the lateral. It looks like it's a left lower lobe, and this is still a left lower lobe pneumonia. تعبتوا ولا ايه؟ لسه
هذا
بدري.
عندنا ميكس.
انا
انت جاي متاخر.
ايه
انت
ايه سوي معايا
جاي متاخر. الغدا عليك. لا, go ahead. You want to shoot? Try. So where's the main problem? Right or left?
What is this on the left?
ايه واتس؟
أظنكوا هنا. This one?
كولون
So it's colon. We know this is the splenic flexure. The splenic flexure طبعا
عم يتحضر
تمام. مش متحضر. ده عكس ده فوق ده over متحضر. So basically there's a lot of gas طبعا. But still the pathology is on the right.
Yeah.
تمام. It's in the mid. Yeah. Can you localize the right? I'm just trying to tell you there's more. So there is right middle, which represents most likely the right upper lobe. Yeah. What about the right cardiac border? It's still difficult to visualize, which is something related to the right cardiac border is most likely related to what?
The right middle.
So could you have, and can we have two lobes at the same time? Is it possible? It's possible. Okay, so if we do lateral, you can actually see that the posterior segment of the right upper lobe and the right middle lobe are both affected. So it's possible. It can happen. Don't be, and you can have a patch on the right and one on the left. So don't miss. You can have two focal, one here and one here. If you go properly and you evaluate properly, yes, you will catch it. Tamam? So this one has two. It has combined right middle lobe and right upper lobe nerve.
Is there a collapse on the right side?
Hmm?
Collapse?
لا بص collapse بقى هتيجي. بس هو collapse, you can't say collapse because the volume is almost, the volume is fine.
Okay.
What do you mean by collapse here?
Yeah.
No, this is just airspace disease. قرب لو عاوز, بس هي airspace ما فيش. White.
Okay.
Collapse, completely white. تمام. What about here? Well, hit this one. It's not bad. ليه بس كده؟ انت طالما متشائم ما تشوفش اكسريز ده ما تشوفش اكسريز. لا really honestly. So where's the main problem? In the right upper, yeah? But is there something unusual? في ايه دكتور؟ شايفه ايه؟
الديفايند ما ادري
الديفاين ماس
ايه يمكن شيء
يعني هو
لانه في شوف هذا الاير
so there is air bronchogram or no? But the borders are what?
لا
Ill-defined actually. This is what we call spiculates, ill-defined infiltrative, and maybe there is what? Breakdown. يعني ممكن can all this was a pathology and they started to what? To break down. Can't say cavity, but there is breakdown. Okay, so it's not the normal lung. This is consolidation with breakdown. This happens with what types of pneumonias? Necrotizing pneumonias. Yeah, necrotizing pneumonias. So usually, if you're having a cavitating pneumonia, you think of necrotizing pneumonia or TB. هو طلع TB الراجل صحيح؟
لا ستيل الحين
يعني هنا negative هنا. Okay, so if you have an apical يعني pathology, it's either related to the rib, pleural, تمام, mediastinal طبعا, lung, which is cancer. This is the most important. The cancer in pancreas, TB, تمام, is one of the pneumonias that affect the upper lobes. There's also another type of of organism that loves the upper lobe. Anybody know? No. No, what? مين قال ايه؟ مش عارف ايه. Klebsiella. Klebsiella is one. خلاص. Friedlander's pneumonia was one of the ones known. So Klebsiella can do that. TB can do that. طبعا fibrosis طبعا من all TB أو radiation قبل كده. يعني these are the main. Yeah. We know those. This is not difficult. So what about here? What does this look like? Yeah. Looks like cavitary lesion is left parahilar, well-defined cavitary lesion. Maybe there is what? يعني the border is speculated, or there is يعني هو هنا one of two things. Exactly. So either there is consolidation next to it, around it, or it's actually. But I think it's well-defined. So I can view the border, and maybe this is consolidation. Then whatever. Yeah. It's and this is what it looks like really on CT. So I want to show you the difference. يعني it might not seem so clear here, but because it's two-dimensional. When we do three-dimensional, then it's very, because all this is affecting what you're seeing.
Yeah.
Okay, so that's what I'm trying to get to you. Don't be reluctant because it's not clearly black. You'll say it's a cavity. It's possible, and this is exactly the same lesion on CT. Okay. So I'd say it's a lung abscess because it's complete. Yani there was fluid, a little bit of fluid inside. Yeah. Okay. What about this one? Where?
Elevated left.
So start focusing. It's most likely will not be the same pathology, but what he realized is that there's an elevation, and then in the lateral it's very clear that there's double diaphragmatic border, and this is a diaphragm. This is what the diaphragm looks like. This is how thick it can be. It can be this thick. What we have here is left eventration or left elevated hemidiaphragm for differential diagnosis. Really, what we usually do with cases like those, it could be old or it could be new. What you should do, you'd order two things. Fluoroscopy. Fluoroscopy would be one of them, whereas actually the patient would go and stand behind an X-ray and breathe. And then if we find it's either paresis or paralysis, they would be able to define that. And then we do sniff tests to even evaluate the power and the function of the diaphragm. And you can also do pulmonary function testing in patient while sitting or standing and while lying down, and it should be affected. There should be a difference between them. It would be worse when the patient's actually lying down. Yeah?
هذا air under diaphragm.
لا ده مش air under diaphragm. ده elevated right left.
how do you tell them apart?
هو طبعا air بيبقى نعم.
لازم يبقى فيه two shadows.
Yes, there's two shadows also. بعدين air will be black. هو واضح هو air will be black it will be black. تمام, it will be black and it will نعم.
It's completely black.
Yes, it's going to be black. There is a difference in the shadow.
هيبقى فيه two shadows. الشادو بتاع الليفت كوبيلر.
Yes.
في الشادو
another double diaphragmatic shadow.
وبعد كده بينهم شادو. لازم يبقى فيه شايفين الستومك مرسوم.
Usually طبعا it's bilateral most of the time. طبعا I'm not saying it can't be unilateral. It can be unilateral pneumoperitoneum. That's what you're talking about. Pneumoperitoneum could be unilateral. Most likely to be bilateral. That would be one. Second of all, طبعا it's a more dense. It's a more jet black.
The diaphragm won't be so raised like this, right?
Doesn't matter. Could be. هو لما المريض يبقى عنده مشكلة قديمة وعنده برضه air other. There is no absolute medicine.
Normally the air under the diaphragm won't be so high. It will be just like
could be or could not. Maybe he already has paralysis for some reason. Then he got pneumoperitoneum. And this same patient, unfortunately, later got. We don't know. But is it both related to each other? Will it cause? No, it should not cause. Any air on the diaphragm in a normal functioning diaphragm should not elevate the diaphragm like this. That's the question. So no, it should not. So what's basically unusual when you compare both right and left?
Okay.
Okay.
Straightening of the radial border.
Start understanding إنه طبعا إحنا when we look برضه we just don't look at pathology. You can look at symmetry. Usually there is symmetry.
The lower border of the
collapse.
Okay, good. Volume. So the volume is less. And then when you look at the pathology, which is what you caught at the beginning, طبعا that you can see that there is طبعا obliteration of the cardiophrenic angle. It's continuous directly down. You cannot really visualize the whole diaphragm. So with the loss of lung volume and homogeneous opacity, homogeneous meaning all white, homogeneous opacity and of the thing, the left cardiophrenic angle, most likely this is represented of left lower lobe collapse. Yes, it is. Yeah. تمام. It's gonna get more difficult.
لا هذا
prominent aortic knuckle.
Prominent aortic knuckle.
وايه الشغل اللي مكمل لتحت؟
Okay, which side?
Right side.
Right side.
ممكن
So right what? If you want to say anatomically, what's unusual? Right what? So you can see the hilum is well visualized here. This is what the hilum looks like. Can you see the right hilum? No. So there's a right hilar shadow. Shadow. We don't. We can't see the right hilum, right? And we can't
Trachea shifted.
see the right cardiac border and the obliterated right cardiophrenic angle. What's this lobe?
Right middle.
This is the right middle lobe. This is what right middle collapse looks like. So this is what actually looks like. This is the actual sign.
Trachea.
طبعا there's a little shift. So what would you say? So if you want to think about what's going on, what would you say? What's this? What's this lesion? Right hilar shadow with
Right middle lobe collapse.
which might mean there's طبعا a right hilar shadow right here. It's actually indenting the airways, by the way. Amen? Okay? And this would represent what? A right hilar mass or shadow with complicated by right middle lobe collapse. This is طبعا for CT imaging طبعا. تمام? What about this lesion? Yes. Left airspace, يعني sorry, fluid level, and this is a rounded constitutional breakdown, or it is an air fluid level, يعني cavity with a fluid level for differential. What about this بقى طبعا؟ طبعا this is the obliteration of the constitutional. يعني when you look at the pleura طبعا what we have is this is called obliteration, and you can visualize the angle here, but the angle here is not visualized, and if it gets worse, طبعا effusion, this is what we call. So effusion is either obliteration of the right constitutional angle or subpulmonic effusion. This is what we call subpulmonic effusion. When you can actually see the diaphragm, but there's a meniscus sign. Okay? But you can actually visualize the diaphragm. This is called subpulmonic effusion. Tamam. Then it becomes moderate, tamam, with typical rising to the axilla, and then it becomes massive effusion. Okay? Massive effusion is two definitions. When you say massive, either the effusion reaches the second anterior rib and above, or any effusion causing mediastinal shift. Any effusion causing mediastinal shift. And massive necessitates drainage. In either definition. When you say massive, this is the... So what you're looking for is actually bypassing the second rib, we call it massive, or any effusion, any amount that's causing mediastinal shift.
معلش هو المايل الصورة دي بعدها
Obliteration of the costophrenic angle, subpulmonic effusion. ده ليه term. نعم؟
المفروض يبقى رايزنج تو اكزيلا.
ما هو حضرتك it is, but it's not enough to cover all the diaphragm. So بص عامله زي المنسكس ازاي؟ هي started. بالعكس they are rising in capillarity والpressure changes that are inside the pleura make it look like it's a meniscus. تمام؟ في مرحلة من المراحل بيبقى كده، والترانزيت اكتر على فكرة من الاكسيد بيدي المنظر ده. عشان بس الدنسيتي بتاعته الله اعلم يبقى more fluid, more watery than actual. بس we see subpulmonic effusion a lot. طبعا في حاجة اسمها برضه insisted fissural effusion. يفضل في الفيشر بس لوحده اللي كانوا بيسموه حاجة اسمها pulmonary pseudo-tumor. يبان كأنه tumor بس it's not a tumor. It's actually just elliptical. يعني تمام؟ It's like an fusiform actually مش elliptical, fusiform shaped mass. Okay? This is طبعا lateral decubitus as we mentioned when you have minimal زي مثلا subpulmonic you want to make sure when you lie the patient in the lateral it trickles down and then you can measure the amount. Every 1 centimeter usually يعني can give equivalent of 500 cc of fluid. So you can even know that if it's tappable or not. You have 1 centimeter, you can you are supposed to be able to blindly tap the patient diagnostically. Okay? بس احنا طبعا يعني بنعتمد اكتر على availability انه يبقى فيه ultrasound which is better. What about this?
We can measure the right.
Hmm?
The left cost of right can do.
Yeah.
Right side.
So the pathology is right or left?
Right.
Right, good. Who said right?
Pneumothorax.
Yeah.
Not sure.
يبقى لازم تبقوا مع بعض على طول بقى. So yes, so there is the pathology is on the right. What happens here طبعا it's difficult to determine where the problem is. But of course when you trace, you can trace a border here. This is jet black. And the difference between both, there is a problem. Either this is more white or this is more black. But in pathology wise, yes, this is more black. And it's causing total lung collapse. And the problem is there is mediastinal shift that's actually crowding, يعني that's causing, يعني starting to cause collapse even on, starting to cause collapse on the left side. And this is what we call
Tension.
tension pneumothorax. And this necessitates immediate drainage, either by wide bore cannula in the second space, or if you can, immediately go ahead with a chest tube. Tamam? This is more clear, the border and where it is, tamam? And what it looks like. This one doesn't have mediastinal shift, that's the difference between both. So you might not call, this is a large pneumothorax with total lung collapse without evidence of يعني tension, or without mediastinal shift yet. Still, يعني the difference in this one is urgent, you must do it immediately. Clinically على فكرة احنا ساعات حتى even without x-ray, you don't need to wait for x-ray to do it. تمام. Here?
Pneumothorax. Pneumothorax.
Right or left?
Right side.
Right.
Right.
So this is what pneumothorax looks like. All you need to do is you need to trace a border. You must trace a border. طبعا if the patient is symptomatic, this is more than 2 centimeters. This also, يعني if the patient's يعني stable with more than 2 centimeters, usually you just drain, you aspirate. On the spot, you can aspirate, remove, re-x-ray him, he's fine, he can go home. Okay, if he's symptomatic, then he should be admitted and we should put a drain and we should drain it under water seal.
Okay.
This one, same?
Same.
Yeah.
But more expensive.
Yes, more extensive than the one before.
Yeah.
Hydropneumothorax.
Hydropneumothorax. So why do you say, is it right or left? You must say.
Left hydropneumothorax.
So there is left-sided hydropneumothorax alone?
Right side pneumonia.
No, you did not complete. So there is left-sided hydropneumo. So what you're describing is you're saying that the left side has air and fluid in the pleura.
That's why it's
With?
push.
Yeah, don't forget. So you did not finish off. يعني انت when you contact me it's different. When you tell me there's mediastinal shift or not, أنا هسألك ممكن بس يعني you should catch it. So yes, you're right. The pathology on the left, it's plural, it's hydropneumo. Why? Because the problem is in إحنا when there is the pleural cavity itself at different pressure, the fluid is usually rising to the axilla due to the permeability. تمام? As long as the pressure inside is maintained, that push of pressure. When it's obliterated with the presence of air, then the fluid becomes levels. It levels out. And this is one of the early signs to determine whether there's pneumothorax or not. Tamam? But there's mediastinal shift. This necessitates also drainage. Left hydropneumothorax with shift. Intercostal tube underwater seal is mandatory. تمام؟ طيب أقول لكم سؤال بقى. So here, when there is pneumothorax, the tube is usually directed with fluid. It's directed.
Yeah.
So what about this case? Where we do it?
شوية فوق بعدين
And
شوية
down.
تحت.
شوية ازاي يعني؟
يوم فوق يوم تحت.
up.
لا نحط اثنين، نحط واحدة فوق وواحدة تحت. No. Usually we try to go midway. Yes.
عشان
Yes, to be able to drain the fluid at the same time drain the air.
air will come out.
تمام. Okay. Or usually طبعا if it's not, then you should go up. Then sometimes you put under suction to be able to bring out all the fluid. Yeah. Okay. But definitely you'd give more towards the, and you'd be more biased to the air than the fluid. تمام. Unilateral طبعا hyperlucent lung. When you have one side that's more black than usual, طبعا one of the causes that are simple is that if it's a female and there is mastectomy, you'll find breast shadow on one side. It's something usually we miss. تمام؟ طبعا usually hyperinflation بنتكلم على any of the causes, either it's congenital or it's acquired as emphysema. تمام؟ Mainly those are the two main things you need to keep in mind. What does this look like?
Hyperinflation.
Bilateral. There's no pneumothorax طبعا. It's usually hyperinflation. What does hyperinflation mean? So when I say hyperinflation, when Faisal comes to me, he calls me, he says there's hyperinflation. So Mahmoud, يبقى أنا متوقع إن يبقى في hypertranslucent lungs. تمام؟ What we call ribbon-shaped heart, low flat diaphragms. تمام؟ وغالبا ممكن يبقى في spacing between the ribs. So this is what I mean by when he says hyperinflation. Our signs of hyperinflation. That means at least there is hypertranslucency, there is low flat diaphragms, there is widening of the ribs, plus or minus a ribbon-shaped heart. You know? This one, what does this look like? نفس الشيء ازاي؟ لا ايه؟ نفس الشيء؟ The ribs are there?
It's not a good X-ray.
Yeah, it's not, but يعني, in general, what does it look like? Hyperinflation.
Male female.
Male female. So this is what happens. ساعات ناس كده تقول لي يعني هو الفيميل can have hyperinflation عادي جدا. عادي جدا. She can have hyperinflation also, and she could be COPD, she could have hyperinflation. What happens is that the breast cells usually interfere and they usually throw people off. It's normal. So you were right at the beginning, your first impression was right. And those are just breast shadows. So yes, exactly. Amen? So this is just hyperinflated male, female. This is reticular nodular. It's true. تمام؟ لأن احنا طبعا كتير we don't see all of this. This يعني أصل دايما تبعتونا على reticular nodular. You can't say honeycombing on a chest X-ray. You can't, unfortunately, and you cannot actually use the term on an X-ray. You need to CT the patient. Yeah, could be highly suggestive of honeycombing, but you can't actually use the term on X-ray. You can use it on CT imaging. تمام? So, but this is reticular nodular. يعني usually reticular nodular is usual diffuse bilateral. تمام? And it's a reticular pattern طبعا with multiple nodularities, and this is what it usually looks like. طبعا ممكن يكون في زي ما حضرتك بتقول مكتوبه ايه يعني cystic changes. It could be cystic changes. Early cystic changes. بس honeycombing you can't say here. تمام؟ Possible here too. Yeah? Yeah, or airway dilatation. لأنه ساعات بيحصل معاهم traction bronchiectasis but we still can't diagnose by X-ray. You need to do HRCT imaging. So this is just to take another infiltrates, early cystic changes for differential diagnosis and diffuse interstitial parenchymal lung diseases كلها. تمام؟ Yeah, not one. Everything, anything can do that. It could be sarcoid that's doing this. You don't know. Steroid responsive. What's this? No, it's not sarcoid. It's not sarcoid.
So this is not sarcoid? Bilateral heart.
We don't know. This is an imaging, imaging.
Okay,
So this
okay.
is bilateral hilar lymphadenopathy for differential diagnosis. Yes, could be sarcoid, could be TB. High suggestive of sarcoid, but this is radiographic. So we have bilateral extensive hilar adenopathy. تمام؟ طبعا البايلاترال هايلر ادينوباثي زي ما انتوا قلتوا طبعا تي بي ساركويد نوموكونيوزس طبعا بس دول بيبقوا كالسيفايد اكتر. تمام؟ الاثنين ممكن يعملوا calcifications. Any granuloma or pneumoconiosis, those all cause calcification. Could be طبعا lymphoma or metastatic malignancy. تمام؟ If it's actually vascular, not true. It could be, but it's totally not the picture you saw. If it's sometimes early or mild or one lymph node on unilateral, yeah, you would put differential. But usually, mainly it's lymphadenopathy. It's lymph node related. And it's CT. Oh, okay.
Widened mediastinum.
Very good, برافو عليك. Very good. Why do you say widening this time? أنا حاربته عبالة تستاهل فعلا. Okay, so so what you realize is that there is widening in the mediastinum. تمام? Which is evident, but يعني when you double check here طبعا, first of all you want to make sure that the patient is well centralized, and yes, when we double checked again, the patient is well centralized, the distance between both clavicles. So yes, there is widening of the mediastinum extending down to the hilar. يعني طبعا for differential diagnosis anything within the superior mediastinum. In this case in specific it was يعني achalasia.
Achalasia?
In this case in specific it was achalasia. تمام؟ But it is widening mediastinal
Serious.
widening for differential diagnosis. نعم؟ For differential diagnosis. Could في اللي قبليها possible. Aneurysm. Yeah, without dissection is more clinical بس يعني
ليش اكليزيا
غريبة achalasia باينة في الجسم.
وايد اصلا؟
ليه لا؟ الاسوفجس لما يبقى لو في مشكله ويبقى dilated الاسوفجس will not give you widening. It will give widening. Any dilatation of the structures that are normally present in the
late
intestine.
يعني late.
يعني thymus والesophagus والaorta any of them. What about this? Oh, it's not good quality, but it's a combination of both. يعني in general, what I'm trying to say is that you can build up in X-rays. It doesn't have to be one thing, but it could be both. And you guys know that there is hilar adenopathy, okay, and there is still also a widening. So it could be widening mediastinum with, but you have to mention both. ده اللي بحاول أقوله يعني هو alone you cut the pathology. تمام ممكن يكون هو نفسه اللي مسبب ال widening بس the both are there. There is widening and there is bilateral adenopathy. زي ما قلنا برضه two lobes can be affected. There could be two pathologies in the same X-ray. Yeah? Here? Nodule?
لا أكبر منها تكون.
هاتشف
كبيرة جدا يا مان.
ماس.
ماس هذه ماس.
ماس هي فعلا هي نود يعني هي a large more larger than nodule it's a mass. So this is a lung mass for differential. Primary thing that comes to your mind is first thing that comes to your mind. It's bronchogenic carcinoma. First thing on your mind, bronchogenic carcinoma. تمام and طبعا other pathologies. This looks like a tumor. So it's a left lung mass. طبعا malignant top of the list. Bronchogenic carcinoma top of the list. Other differentials طبعا ممكن تطلع abscess أي other benign sequestration whatever. All these things are different. But with the workup you're gonna work up the patient anyway. And I like to keep it simple. If it's a mass, put it priority CT. Then you'll diagnose whatever is going on. بس يعني don't let it go. So it's easier. And we don't need to dig in a lot about talking about it. Nodules يمكن أكتر عشان نعرف characterize الأمور دي. إنما mass straightforward. طيب this is enlarged hilums. طبعا the same thing with the enlarged hilum. It could be lymph node. طبعا sarcoid, TB, secondary lung cancer, all of that sort. What does this look like?
مليون
This is what nodule looks like. This is what nodule looks like. ما هي كده it sets you off. Yeah. So this is what the nodule looks like. يعني somewhere between 1 and 3 centimeters. يعني there could be كمان يعني extent calcification. As you can see, it's more dense.
في شيء تحت كذا صاير رايت ليفت
ممكن تكون
لور رايت
early nodular possible. Nodular disease يعني.
رايت لور بوزيشن
Nice. So there's a shadow down there. طبعا this يعني this if it was me it's like a double diaphragm. تمام. I would put يعني hernia, diaphragmatic hernia top of the list here. Yeah. But you won't be able to identify or confirm except with CT imaging. Most of the people بيجوا لنا كده حتى pre-ops والحاجات دي بيجوا abnormal X-rays للأسف. With whatever suspicion you have to do CT imaging. عادة بيعملوا CT and they're exposed and we just diagnose it and still nothing to be done. Usually most of them live with it. There's two types of diaphragmatic hernia. There is ventral and there's dorsal, Morgagni and Bogdanic, but sometimes most of the patients are asymptomatic.
Okay.
So but the main طبعا is the nodule. طبعا it could be also multiple. وزي ما بقول لكم more common likely ان هي تبقى even if it's bilateral it's more on the right. That's multiple well-defined nodules. Some are calcified. نعم.
مو كان البول؟
يعني المفروض بيبقى اكبر من كده شويه. هم دول يعني multiple وممكن يكون عشان كده بيبقى يعني بس.
What was the case here?
This is برضه metastatic with calcification. تمام on the right side. It's also metastatic but most likely coming from a germ cell tumor يعني choriocarcinoma او حاجه من الحاجات دي. هو اللي بيبعتوا كده.
عشان calcification يعني؟
هم blood. لا هم they spread by blood more. Usually we see those with blood spread. So the more common blood spread.
انا نسوي لهم pregnancy test بالكاميرا.
أيوه هلا.
I think it's one of the things that you بس احنا عندنا ما عندناش بس احنا لازم تعمل بلاد بتاعي مش يورين.
لا انا مرة يعني واحد بالفروانية
أول
كذي
مرة.
سويت له
يورين؟ لا بلاد.
young عمره 26
It's the
28.
blood, it's not urine, he means.
Yeah.
Yeah,
So what's
because
the
you're
اصل احنا هنا ما عندناش بي اتش سي بلاد او يمكن موجود بس لازم يعني I don't بس you can't just order it.
I think the one hand because they have this OBGYN.
That's why here
So
no.
here no.
They won't do it. هم قافلين الباب ده تماما عشان الناس كلها هتيجي تقول لك I wanna check you know what I mean قافلينه they don't have oxygen فقافلينه. It's there but usually what we depend on is urine and it will not be positive. Okay. So this is salty palmy nodule mainly granulomas طبعا بنحطها granuloma hamartoma it could be طبعا carcinoma زي ما قلنا بس تبقى السبلورال اكتر اللي هم ال upper lobe اكتر من lower lobe. Yeah. بس that's it. multinodular the same برضو TB وهيستو طبعا secondary بدل primary ده الفرق. لما يبقى عندك solitary nodule you think more bronchogenic. If it's multiple you'll think more metastatic. And basically they're both main common causes are the same. You know what I'm trying to say? يعني TB histoplasmosis في nodular sarcoid which is rare بس برضه sarcoid ممكن يجي nodular بنفس الطريقة دي. بس it's rare, it's not common. Good?
Yeah.
Yeah. Good. انت هتظبط ده بقى.